Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to today's milestone in our journey of Diabetes Essentials 52 weeks, Dr. Sanjay Kalra sir. Dear viewers, these online modules are an educational initiative from Energal Zero and in memory of late Dr. K.K. Agarwal sir. Insulin distress is an emotional response of the patient to the suggested use of insulin, which acts as a major barrier in insulin therapy in the management of diabetes mellitus. Therefore, addressing patient, physician, and drug related factors is very important to overcome insulin distress. Strengthening of communication between physicians and patients with diabetes and enhancing the patient's coping skills are prerequisites to create a sense of comfort with the use of insulin. And therefore, insulin motivation is a key to achieving targeted goals in diabetes care. So, to take us on today's important topic of insulin motivation, before I hand over the platform to Dr. Kalra sir, let me have the opportunity of announcing the names of those doctors who have answered the quiz questions correctly in the last episode. And the names are Dr. Manu Sharma, Dr. Sumita Sharma from Delhi, Dr. Shahid Hussain Sofi from Jammu and Kashmir. From Maharashtra, we have Dr. Dharmika Tandon, Dr. DG Parmar, Dr. Girish Kesota, Dr. Hitesh Vora, Dr. Kulbhushan Tandon, Dr. Suresh Pawar. From Odisha, we have Dr. Gangadhar Rath. From Punjab, we have Dr. Namrata Puri, Dr. Sanjeev Puri. From Uttar Pradesh, we have Dr. Surjit Kalsi. And from West Bengal, we have Dr. Santanu Kumar Bhattacharya. Dear viewers, last episode, Dr. Kalra sir took us through insulin regimes and preparations. This is one of the important topics and all the important parts which our daily physicians face in their OPD. If any of the viewers has missed to attend, they can view the same module on the same platform itself in the archive section. With this, I hand over the platform to Dr. Kalra sir to take us to today's module. So over to you.
Thank you, Rahul, and good evening, friends. It's a pleasure being with you. Uh, Today, we'll be talking about something that is really important. And I honestly feel I've completed nearly 25 years in endocrinology now. This is perhaps the most difficult topic that we face in day to day practice. And that topic is insulin motivation. How do you motivate someone to take insulin? If you've already motivated someone to take insulin, how do you motivate the person to continue? And if the person is continuing, how do you titrate properly? How do you motivate the person to change the doses or to intensify if required? So we'll talk today about insulin motivation. And the reason for speaking about it is because people need motivation. Why do they need motivation? Because they resist insulin. Now, there are three types of insulin resistance. The first is biomedical. That means there is actually a resistance at the level of the insulin receptors. Within this, there are three aspects, three organ systems which are most important: the liver, the skeletal muscle, and the adipose tissue. So that is biomedical with three aspects to it: liver, skeletal muscle, and adipose tissue. The second one is social insulin resistance. Social insulin resistance manifests as the entire society feeling that insulin is wrong, insulin is unnecessary. It is part and parcel of society's resistance to modern medicine, where society says that we would rather take alternative medicine, we would rather starve, we would rather die than take insulin. That is a societal ill. And the third type is psychologic. Psychologic insulin resistance, it's also known as PIR. This leads to insulin refusal, insulin rejection, insulin hesitancy, and it's quite common in people with type 2 diabetes. Not only do people hesitate to take insulin or sometimes outright refuse and reject it, even if they start, many of them will not continue. Even if they continue, many of them will take in suboptimal regimens or suboptimal doses. Like, for example, you might have prescribed 3 times a day insulin, patient will end up taking 2 times. So it is quite common, this psychological insulin resistance. And along with social insulin resistance, you will find that there are many myths associated. And we all know these. Some of your patients will come and tell you that insulin has side effects like pain, hypoglycemia. Insulin is addictive. insulin is too expensive or too intrusive, or insulin causes complications, insulin causes death. This is what people will come and tell you. Many people will feel that taking insulin means that I'm a failure, while it's not like that. There are others who will say that I don't have any myths or anything, but I'm just afraid. And I will be perceived to be sick by my family, by my community. So I don't want to take this drug. Because of all these things and multiple other issues, some people are apprehensive of insulin. Others feel discomfort, and yet others get dejected. They become sad. If these emotions are present in extreme, in severe degree, that is severe apprehension, discomfort, or dejection, this is known as insulin distress. And insulin distress is a major barrier to optimal insulin use. So you must have seen when you talk about insulin, sometimes patients become very upset, they become unhappy. So how do we handle this? First of all, we have to be able to recognize diabetes distress. Then we have to understand the etiology. The etiology is that there is a perceived wrong conception about insulin therapy. So the perception is wrong. If you know that diabetes distress exists, insulin distress exists, and if you know that it is because of perception disorder, then the aim is to correct the perception. How will you correct the perception? By applying what we call the biopsychosocial model of health. Of course, you will focus on biology, biomedical issues, but do not forget to talk about social health and also psychological health. While you are giving an insulin prescription, you also need to give counseling, education, support. This is what we call VAT, value added therapy. And this counseling can be sequential, it can be simultaneous. Let us look at both of these things. Today, a patient comes to you with diabetes. Patient is going to stay with you for the next 20 years. You know that now gradually the OAD requirement is going up. So maybe next year we will need to give insulin. So right now, you start counseling. So sequential counseling, we will start counseling today. Sooner or later, you made insulin. So we'll be prepared for it when the time comes. We'll keep on getting the test done every 3 months. It's not a big deal. And this counseling will later on change into a prescription. This is sequential. In other cases, it may be simultaneous. The patient has suddenly come with a complication, an acute medical or surgical or obstetric issue, which requires immediate redressal or reversal of hyperglycemia, which requires insulin. So simultaneously, we'll prescribe insulin and give the counseling and support as well. In other cases, some cases, patient may come in lying down, patient may be sick, comatose. So first you start insulin, after that you counsel. So all situations are possible in our practice. Challenges have no end, and we are all aware of these challenges. Difficulty in starting insulin, sticking to insulin. And what we need, if you have these issues, is to have a good start. So this is most important. This slide, let's spend some time on it. If you have a good start with your patient, you will end up having a good race, a good journey, and a good end. So the first conversation should be a very good conversation. So begin talking about insulin before it is required. Counsel your patient, empower your patient so that he or she is able to self-manage. Educate your patient with whatever is required. You can do it in your face-to-face visits. Your staff can do it. You can put up brochures, pamphlets. You can set up a TV screen in your hospital. All these things can be done. And you will be able to give yourself a good start. Also, remember that we are human beings as doctors. We also have psychological issues, social challenges, psychological challenges. So, how easy is it for us to change our own behavior? It's not all that easy. I'm trying to reduce weight. I'm able to change almost all my behaviors except my late evening snacking. So, it is tough for me. Similarly, understand that your patient is also a human being. It is difficult for him or her to change behavior. So how can we help the patient do that? Keep clear communication. Just one or two simple messages. Apply the teach back method. So, madam, I have taught you how to use the glucometer. Would you like to teach me again? So, let's see if she is able to repeat what you've told. Focus on just one or two recommendations. What I do when I talk about diet, two positive suggestions, maybe eat more brinjal, eat more cheese, and two negative ones, don't eat sugar, don't eat butter and cream. So this is a simple way of ensuring that whatever you have said goes into the patient's mind. One size will never fit all. So each patient is unique, each patient is different. They will need different recommendations. And keep the right timing, the proper timing. Now it is mango season, so these days we will talk about how much mango can be eaten by a particular patient. But no point in talking about mangoes during winter when they are not available. That time maybe we will talk about the winter sweets, whatever is available in winter. Like in north we have panjiri, so we'll talk about that. And also, while you're doing this, always remember to be non-judgmental, non-critical, non-sarcastic. Be empathetic, be supportive, be friends with your patient. Just be a human being. So now let me share a few tools that help us motivate patients to take insulin, motivate patients to accept good quality diabetes care. The following slides are in the form of a kit, a toolkit. So feel free to use these tools as and when required. One approach which I use with all patients is the water approach. This should inform each and every interaction that we have with our patient. So W is for warm welcome, A is for ask and assess, T is for tell the truth. Once you have welcomed the patient, ask and assess what the patient wants to know, what the patient's problems are. Then you respond. So first you ask, then you tell. Once you have told the patient whatever is required, that's not enough. Apart from telling the truth, you have to explain with empathy. So explain in a way that the patient is able to understand. And once you've done that, remember to complete the loop with R. R for reassure, R for return. So make sure that you say, okay, today we've not been able to cover everything. When you come back next week, we'll talk more about insulin. Or maybe I've written a prescription. Now we need to follow up. After 4 weeks, let's see how glucose levels are, and then we'll change the dose if required. So water is a tool that should inform each and every conversation of yours in the clinic. Welcome warmly, ask and assess, tell the truth, explain with empathy, reassure and return. There will be times when patients will be angry at you. They will be annoyed at you. They may be anxious. They may be afraid. What do we do then? So in any kind of a situation where you're facing resistance, anger, annoyance, fear, anxiety, what you do is you express empathy. So the first thing to do is, madam, I understand what you're going through. And I can understand that you dislike insulin, and you've also explained to me the reasons why you dislike it. So I understand. The second is roll with resistance. Just flow with the current. If you're going to argue with an argumentative patient, all that you're going to get back in return is an argument. And whatever happens to the patient's glucose or blood pressure, that is separate matter, but your own BP and glucose will rise. So there's no point in fighting argument with argument. We are not trying to win a debate. So let us roll with resistance. Express empathy, roll with resistance. Okay, today you don't want to take insulin. Our final aim is good glucose control. Let's see what else we can do. You have disagreed to take a statin. You feel that statins are bad for health. That's fine. I respect your decision. But we actually need to get your CV risk down. What else can we do to bring down CV risk? Once you've started this discussion, do not push back upon the patient. Find a tangent, find a lateral entry into the patient's mind. And then you develop discrepancy within the patient's mind. Madam, you just said that you do not want to take insulin at all. But you also said that you understand the value of good glucose control. And now you do understand that if we achieve good glucose control, all these infections that you have been facing for the past 3 months will vanish. The symptoms that have been troubling you will vanish. What's more important? A good sleep at night, a happy daytime, or the pain or maybe the prick of an insulin just 5 or 10 seconds twice a day? So, what do you think, madam? What is more important? What is more meaningful? Yes, madam, you did say that you want a happy life. You want 24 hours of good health. So, what is the cost that you are willing to pay for 24 hours of good health? So, this is a way of developing discrepancy. But you will be able to develop it only if you are able to enter the patient's mind, if you're able to kickstart a conversation, and you can do that by a lateral entry. Not only is it enough to express empathy and to use the right words to keep the patient discussing and to keep the patient engaged. So, express empathy, engage the patient in meaningful discussion. But it's also important, apart from expressing empathy and engaging the patient, to make sure that the patient is efficacious, is empowered, is effective in supporting himself or herself. So, in the meantime, you equip the patient with more information, more knowledge. See, madam, how easy it is to take insulin. See how easy it is to use a glucometer. You keep on doing this. All this will not happen in 2 minutes or 3 minutes, but it will happen over time. And diabetes is a chronic disease. Usually, it gives us time, provided that we begin in a timely manner. So, now all these things that are coming to our mind while we are listening to this talk is that we can actually engage with many of our patients in a meaningful manner. Maybe not all patients on all days, but yes, with most patients on most days, we can find time for this. And you don't have to do everything in one visit. You just roll with resistance, keep the patient engaged, call the patient again next week or next month. So just keep the conversation going. If you do that, you will be able to initiate and intensify insulin, also titrate it. But before initiation, we have a pre-initiation toolkit. So if you have a patient with high HbA1c or a diagnosis, do communicate that diabetes is a progressive disorder and we can use insulin at any time. Maybe today we have decided to start OADs, but in case it doesn't work, insulin is always there as an option for us. Just inform the patient, let it be in the patient's mind. If you're not able to achieve glycemic targets after 1 or 2 months, then you reinforce this. Yes, we did speak about it 2 months ago. At that time, I felt that we could manage without insulin, but now that we can't and we need long term health, sustainable health, let's think of insulin again. If your patient has had long standing diabetes, maybe more than 10 years, patient is already on 2 or 3 OADs, patient has got comorbid conditions which are due to uncontrolled diabetes, then you educate the patient. Use positive language. Instead of saying, poor glucose will worsen your kidneys, why can't we say, good glucose control using insulin will improve our kidney health, will keep our kidneys healthy and young? So introduce these concepts of longevity, youth, happiness in your conversation and try it out now while we are speaking. Whatever language you are speaking, whether it's Marathi, Telugu, Bangla, Malayalam, just think positive, say positive. Madam, insulin will help you maintain that wonderful smile that you have. It will keep your skin youthful. It will keep you happy. It will keep you happy. It will keep all your organs, all your systems happy and young. You will be able to do whatever you want to in life, whether it is climbing Mount Everest, whether it is going for a pilgrimage. So, this is the way to pre-initiate insulin therapy. And depending upon what the patient says, you answer back. So, first you ask and assess. After asking and assessing, you tell the truth. If patient says, I'm afraid of social stigma, then you offer social support. If patient says, I'm afraid of biomedical complications, then you reassure the patient that actually insulin will improve biomedical health, not worsen it. You can do it in a one-to-one meeting. You can do it as part of a group interaction. You can also refer the patient to various videos or various sites that you trust on social media. Now, once the patient agrees to take insulin because it's required, then you need a separate toolkit. Then you need to demonstrate how easy it is to take insulin. So you discuss with the patient 4 injections, 3 injections, 2 per day, what is required, pen or syringe and vial. If it's a pen, reusable or disposable. It will depend upon the patient actually what you want to prescribe. If you yourself feel that insulin will be required just for a few weeks, then disposable pens are good. Let the patient use disposable pen once or twice, and then if you feel insulin will be required for many months, then you ask the patient to invest in a reusable pen. But most of the pharma companies, pharmaceutical companies, will actually give the reusable pens free of cost. If patient wishes to use syringe and vial, that's also fine. So we'll talk to the patient about that. Demonstrate how easy it is to use, demonstrate the flexibility of insulin, and move ahead. Make sure that the first injection is given in the OPD so that patient doesn't feel afraid. Once that has been done, now we need to titrate. So here we need a toolkit. Some of us will prefer fixed insulin doses, which means, madam, you take 10 units twice a day, come back after 15 days, we'll titrate at that time. Others will say titration. And in that, some people will say, madam, I'll teach you this regimen. You titrate on your own. Twice a week, you do your glucose values. This is your target. If glucose values are above target, increase by 2 units. If they are within target, zero change. If you get hypoglycemia and you go below target, then you reduce by 2 units. So 202, 2 by 7. 202 titration framework twice a week. There will be others who will say, you just check your glucose and let me know on WhatsApp or let my staff know, and I will change the dosage for you. So it's fine. Whatever works for your practice, we are fine with that. In titration, do remember that if the patient is on basal bolus regimen, more frequent titration will be required. If patient is on ultra long acting, like degludec or glargine U300, then less frequent titration will be required. Premixed will come in the middle. Now for intensification, this is also a challenge. Sometimes patients will start 1 or 2 doses a day, 1 basal or 2 premixed, but then glucose levels don't come down, so you have to help them intensify. There also there will be a lot of resistance, especially for the lunch injection. So you get away with it, you get around it by saying, madam, try it for 2 or 4 weeks, because otherwise you see that foot ulcer is not healing. Let's give it for a few weeks. Once the glucotoxicity comes down, once the lipotoxicity comes down, we can always de-escalate the regimen. So that is a way of helping the patient accept intensification. We call it a finite request. Request for intensification for just 2 or 4 weeks. Decide upon a predetermined endpoint as well. We will continue giving you these injections until you become symptom free. We will give these injections until maybe you begin gaining weight. That will be a sign that we have gone into anabolic phase. After that, we can reduce the insulin. So all this discussion should be done. Like I said, when we began, this is one of the toughest topics in diabetes care. It is also one that I'm most passionate about. And we'll be happy to share references with you for these toolkits, how you can use these toolkits to improve the quality of your practice and improve satisfaction of your patients. One of the articles that we have used here will be published in the Indian Journal of Clinical Practice next month, and we can give you prints of that as well. But before we conclude, let's take our quiz for today. We have one question. So what's the difference between type 1 and type 2 diabetes? Let's see, one of these is correct. A, type 2 diabetes patients require lower doses of insulin than those with type 1 because they have a milder form of diabetes. Is that true or not? B, patients with type 1 diabetes rapidly develop chronic complications. C, autoimmune factors are involved in type 1 but not in type 2 diabetes. So is this right or wrong? And D, persons with type 2 diabetes can increase endogenous insulin production by taking oral hypoglycemics, but not type 1. So which of these is the most correct statement? You have to choose only one. So we are trying to differentiate type 1 and type 2. So let me repeat all of them. Which of these is the most correct? That's our question. Patients with type 2 diabetes require lower doses of insulin. That's A. People with type 1 diabetes develop chronic complications more rapidly. That's B. Autoimmune factors are involved only in type 1 but not in type 2. That is option C. And option D is type 2 diabetes patients can increase their endogenous insulin production by taking oral drugs. So with this, we come to the end of today's talk. Let's see what questions we have for today. And lots of questions, lots of comments also. Dr. Nitin Narula asked about neuromuscular pain. Dr. Nitin, if you allow, we can take this up in a later session. Dr. Dharmaraj says HbA1c 12, but patient is asymptomatic, absolutely normal. We can start OADs, sir, in such a patient. The books don't say so, but in India, this is common. You start with OADs. A good idea would be, Dr. Gauri Shankar, to tell your patient, see, the textbook says I should be giving you insulin. This is a true statement. But when I look at you, I get a very good feeling. I have a feeling that you are going to take good care of yourself. Your spouse is with you. I get a feeling that your spouse is also very cooperative. So if we work together, I'm sure we'll be able to come out of this. If insulin is required, we'll give it. That's also not a major deal. It's not a big deal, but let's try for a few weeks and see what happens. We will get an HbA1c done after 4 or 6 weeks, usually 6 weeks in my practice. We will not wait for 3 months. Why so? It's not that you are more sick, it's that you are less sick. And we have a feeling that from 12, you will come down straight to 9 within 6 weeks. So let us see what happens. We will be able to de-escalate therapy at that time. So in such a patient, if the patient is asymptomatic, we can start triple oral therapy. Metformin plus any two more, DPP4 inhibitor or sulfonylurea or SGLT2 inhibitor. I mean, any two out of these, DPP4 inhibitor, SGLT2 inhibitor, and sulfonylurea, any two out of these, plus metformin. Another clinical case that Dr. Gauri Shankar shares is, again, HbA1c 12. Patient is already on 3 drugs and is asymptomatic. That is BMI 27, age 45. Now, if the patient is actually following diet and exercise, then there is no point in adding a fourth OAD. You can, if you want, add SGLT2 inhibitor. You can add GLP-1RA, that will help in reducing weight, but it is highly unlikely that patient will come down to 7. So we should start insulin. If, however, patient has never been following diet and exercise, then you focus on that. You say, we want a strict dietary regimen. We want you to begin exercising. Let's see what happens in 4 to 6 weeks. So basically, it will depend upon the current status of diet and exercise, and also how much the patient is willing to commit to. So this particular patient with 3 OADs, what I would do is maybe I would give the patient options. So I might say, ideally, we should be giving you 4 injections. There is another tablet that is oral semaglutide. It costs 300 rupees a day. So these are the 2 options we have. Now, for both of them, even if I were a patient, I would step back and I would say, Dr. Dharmaraj, I think I need to find a new doctor. So then we'll say, but let's try. If you promise to follow diet and exercise, why don't I put you on premixed insulin? You have to take only 2 injections a day. And we'll take off the sulfonylurea as well. It is not that we are going to increase your dosage. We are just going to change a tablet into an injection. So let's see what happens. If patient agrees, well and good. If patient doesn't agree, then you add a 4th drug, but call the patient back after 2 weeks or so. Recheck HbA1c in my OPD at 6 weeks. The reason why we do HbA1c at 4 or 6 weeks is that 50% of HbA1c weightage comes from the previous 28 days. So there is actually a meaningful difference that you can see in such patients. And Dr. Manoj Yadav, thank you for pointing this out, that if you communicate in a very simple manner, in a confident manner with your patient, patient also listens. We have other questions coming in. Dr. Vinay Desai asks, how much Inerzail Zero can be consumed in a day? As much as the patient wants. So I use this now in summer. I use it a lot. Some patients coming with heat exhaustion, others with weakness for whatever reason. Other patients who are very symptomatic, they come in with, we have a lot of poor patients who come in with very poorly controlled diabetes. We start them on insulin and send them home. We don't admit them. So, and they are thirsty all the time. So we say you can take some Enerzel Zero as well. It's a different taste. It's a good taste. Your electrolyte balance will be maintained. You will not get hypokalemia. Dr. Gangadhar Rath asks about postprandial glucose being lower than fasting. Yes, the explanation is, the scientific explanation is as follows. Fasting glucose is mediated by hepatic gluconeogenesis. It comes from the liver. It is a protective mechanism for animals. Supposing a lion begins attacks you at night, how will you save yourself? You have to run away. You need glucose. You need energy. So fasting glucose comes from the liver. Postprandial glucose is mediated by insulin receptors in the skeletal muscle and adipose tissue. If there is selective hepatic insulin resistance, that will cause increase in fasting glucose. How we explain to the patient? We say this comes from the liver. Daytime glucose is linked with your daily routine. In Hindi, आपकी दिन की शुगर आपकी दिनचर्या से बनती है. Your daytime glucose is based upon your daytime regimen or routine. Because you are taking such good care of yourself in terms of diet and exercise, that is why your postprandial glucose is coming down. And for fasting, of course, diet and exercise do have an impact. Sleep, good quality sleep hygiene has an impact. If you take alcohol at night, that will worsen fasting glucose. If you're in a night shift or in a changing shift duty, that will worsen fasting glucose. But I would like to commend you, sir. You have done such a good job of self-management. Your postprandial glucose has come down. Now we can reduce your morning glucose dose, glucose lowering dose. If it's insulin or OAD, whatever, we will reduce the daytime dose. And for night, gradually, don't worry, we are giving you the medicines. There will be no complication. Gradually, maybe the liver resistance will also come down. In very few patients, Dr. Rath, sometimes we have to prescribe an anxiolytic at night that brings down the fasting glucose. So you can use alprazolam, etizolam, clonazepam, whatever you're comfortable with. But these are addictive drugs. The drug of choice for sleep would be either zolpidem or lemborexant. These are the best drugs to use. If your patient is on insulin and fasting glucose is high, you also have to keep in mind something called Somogi phenomenon or rebound phenomenon, which means that glucose falls during the night at around 3 a.m. It goes to below 56, below 70, and then the counter-regulatory hormones come into play, and because of that, glucose increases. In such cases, you will have to reduce the dose of nighttime insulin. There are other patients who will have what is known as the dawn phenomenon. And this is because maybe the long-acting insulin is not acting long enough. So here we have to shift the patients to ultra-long-acting insulin so that they can counteract this. Ultra-long-acting insulin can counteract the dawn-related rise in counter-regulatory hormones like cortisol, testosterone. All these lead to high glucose. Another point is when a patient in need of insulin refuses it, I sometimes tell him that he may develop kidney problem, blindness, and heart attack sooner or later. I also do the same sometime, but it is not correct. We can use positive language. When I get irritated or frustrated, I also say this, but then I feel very bad inside me, actually, Dr. Rath. The best way would be a positive motivation. Sir, insulin is your friend. It is there to help you. It will help prevent kidney disease. It will protect your heart. It will promote good health. It will keep you young. It will keep you young in the mind, young in the heart, young in the body as well. Sir, why don't you try it and see? So a positive motivation would be better. Dr. DG Parmar asks about blood pressure. So usually we do it in sitting position after the patient has been sitting at rest for a few minutes. But if you're worried about postural hypotension, then we will have to do all three: supine, sitting, and standing. But otherwise, the guidelines say that we should check for blood pressure in the sitting posture. If patient is on glargine U100 20 units, this question is from Dr. Vinay, then what is the glargine 300 dose? Usually it will be around 24 units, usually, but start at 20 units only when you change, and tell the patient we will check glucose once or twice a week. If required, we will change the dose. Also tell the patient that we are giving you a new insulin. So sometimes it takes 3-4 days for the steady state to come. But in general, about a 10% increase will be required. If a patient is on glargine U100, 20 units, and also OAD is not controlled, how do we calculate the premix dose? Okay, so 20 units glargine means 20 units basal. So when I shift to premix, I want to give at least 20 units basal, at least. To give 20 units basal, I will have to give 30 units of premixed because it's a 30-70 ratio. So this 30 units of premix, if I'm giving analog, I will divide as 15 with breakfast, 15 with dinner. 50-50 division I will do. If I'm giving human insulin, then I will do a 2/3, 1/3 division. So total was 30 units. I will give 20 units at breakfast and 10 units at dinner. This is for human premixed, human 30-70. So this is a rough way of starting. Count the total basal dose, which is 20. Convert it to premixed, that is, it becomes 30. If you're taking premixed 30-70 or 25-75. This 30 units, how do we divide? For analog, you divide 50-50. For human insulin, you divide 2/3, 1/3. And then you can titrate every second day, every third day. So these are all the questions that we had today. I hope that we've been able to help you. This is always work in progress, how to prescribe insulin, how to motivate patients to take insulin. And I hope that through this dialogue that we are having, we will be able to motivate our patients better. Feel free to ask for the references from the team FDC when the team visits you. And if there is any other comment, any criticism, any particular question that you have regarding this, please let us know and we'll try to address it in future issues. So with this, I'd like to thank you, and I'd like to go back to, we have a couple of more questions. So before we go back to team FDC, one last question is it correct to estimate thyroid function before starting statins? Not necessary. If you have someone with type 1 diabetes, you must do TSH every year. If you have someone with type 2 diabetes and the patient has other factors where you're thinking of thyroid, maybe glycemic variability, hypoglycemia, hyperglycemia, maybe depression, dyslipidemia, fatty liver, then in such cases, we will do a TSH, but not specifically for statins. So with this, I'd like to hand the stage back to Team FDC, and I look forward to meeting you again next week.
Thank you, sir. Today's session was very important in terms of motivating our doctors and healthcare providers to reduce the therapeutic inertia, because most of the time I remember Dr. Ganda speaking in our Diabetes Essential in conversation with Dr. Sanjay Kalra, saying therapeutic inertia is also been seen in one of major factors in missing the goals in India specifically, sir. So I'm sure with today's motivating session with Dr. Sanjay Kalra, I'm sure many of the doctors will change their or dialogue with the patients and try get many patients on insulin. This will help each one of the patients getting into achieving their individual goals. With this, I thank Dr. Sanjay Kalra for taking tough session today because it was very important. Thank you, sir. Jai Hind.
Jai Hind.